So I start now.
Yeah.
So good afternoon, everybody. So I'm very happy to participate as a second speaker on this webinar for the network, European Reference Network NMD. And the talk is about amyloid neuropathies to make an update on this topic, which is very exciting in the field of neuromuscular disease, because we have made major advances in the last 30 years. It is the most severe hereditary neuropathy in the adult, and we have now made considerable progress during the last 3 years from the diagnosis to therapies, and we have now 4 different therapies for this rare but this devastating disease. So just to remind what amyloidosis is this is a result of accumulation of amyloids in the tissue, especially in so amyloid deposits are made of fibrils, which are polymers comprising identical monomers, and it's in neuropathy, it's extracellular deposits. The characteristics are, as you can see, Congo red staining on this nerve biopsy, the special apple green birefringence and Congo red staining with polarized microscopy. And if you have on electron microscopy examination, you have typical fibrils, 10 nanometers in width and undetermined length. This is an antibody against TTR. And the protein fibrils are aligned at squat beta sheet. The amyloid nomenclature has changed by the International Society of Amyloidosis recently, and we talk usually of familial amyloid polyneuropathy, and now the nomenclature has changed, so we have to consider the protein, and the name is changing. So there are different amyloid proteins able to induce peripheral neuropathy. The most common is ATTR as transthyretin, but also a Finnish type with gelzoline. Apolipoprotein A1 also is possible, only one family in the United States, and recently in France, the A-beta-2 microglobulin by Professor Valex in France. And when this is hereditary neuropathies, but there is also acquired neuropathy with light chain AL amyloidosis, which is possible. I will focus my talk on the hereditary familial polyneuropathy and transthyretin, because the large progress have been done in this field. So instead of talking about familial amyloid polyneuropathy of transthyretin, we are talking about transthyretin amyloidosis, ATTR amyloidosis. It is very important because in the different papers it will be taken like that. So instead of FAP, familial amyloid polyneuropathy, hereditary transthyretin amyloidosis associated with polyneuropathy, ATTR-V for variant and PN for polyneuropathy. For example, for the most common variant, VAL30M, you have V30M, ATTR-V30M, and so on. For the nomenclature also, for when we're talking about amino acid, you can put a P at the beginning and to put 20 more ATTR-V30M. The epidemiology now has changed during the last 30 years. It was supposed to be an endemic disease in a few countries like Portugal, Sweden, specific region of Japan before the 90s, and now we can consider a worldwide disease in the United States, in China, in South America, in every country in Europe, you can find ATTR polyneuropathy, amyloidosis. The range, the global prevalence is estimated about 10 per 1 million people, but the range considered variable between the north of Portugal, 1 per 1,000 people, and to other countries. The estimation is recent by Professor Schmidt in recent review in muscle nerve and considered the main focus in the world. This is a picture of ATTR amyloidosis in the before 90s. With the blue, you can see the countries: Sweden, north of Portugal, some area in Japan, and also Mallorca and Cyprus, and some patients in Brazil. And now, this was only one variant at this time, but now we have more than 50 different TTR variants in the world, and you see the different major countries: United States, China, recently reported Bulgaria, and so on. So there are many countries with more than 30 variants recently. The transthyretin is the other name is prealbumin. It is a tetrameric protein with 4 identical subunits. The molecular mass is 55 kilodalton, and particularly there is a central channel with a thyroxine binding site. The role is to transport protein for thyroxine and retinol binding protein associated with vitamin A. It is present in the serum and CSF. It is produced by the liver as a majority, the retina, and also the choroid plexus. That could be explaining some complications, systemic complications. The pathophysiology of the peripheral neuropathy in ATTR variant has been reported recently by Haruki Koike, Japanese professor and specialist in peripheral neuropathy, who explained that large electron microscopy study in the peripheral neuropathy of amyloidosis showing that the disruption of blood nerve barriers, the first step, the introduction in the endoneurium of amorphous materials, the seeds of amyloid, the constitution inside of amyloid fibers, and finally severe toxicity on the Schwann cells, inducing Schwann cell atrophy. So the tetramer of the TTR is dissociated as monomer, making oligomers and building fibrils in the different tissue. Here are the different sites of amyloid deposits. This is a systemic disease, and the amyloid deposits produced by the liver is going different tissue. First of all the somatic peripheral nerve, and also the autonomic nervous system. And using, this is some all along the roots, the plexus, the distal trunks, and using, as you can see, sensory denervation and distal sensory loss in the lower limbs, and gloves distribution upper limbs, and also motor denervation with weakness, especially in distal part of the limbs, but it would be inducing sometimes tetraparesia. The consequence of autonomic denervation is very important for this patient, especially for male gender with erectile dysfunction first, severe digestive disorders, cardiac autonomic dysfunction with orthostatic hypotension, and also poor sideral function. Here, for this multisystemic disease with multi-dimension, with sensorimotor involvement, autonomic involvement, and extra neuropathic involvement. Sensorimotor with sensory loss at the beginning and pain in the feet, extension, and after that, motor difficulties, and the consequences, the loss of locomotion at the end. And the first autonomic dysfunction is erectile dysfunction, digestive disorders, and at the end, at severe and late stage orthostatic hypotension, and urinary incontinence. The extraneuropathic consequences are, from the cardiac point of view, the conjunction disorders, restrictive cardiopathy, ophthalmologic consequence, renal involvement, weight loss, which can be inaugural in some patients, and late cerebromeningeal complications. There is a very large phenotypic heterogeneity in ATTR polyneuropathy. We were knowing from Corino Andrade since 1952 the typical length-dependent small fiber polyneuropathy with autonomic dysfunction in young people. But now, in late onset, in the same variant, we have all fiber polyneuropathy, and Eric Koike has described in a beautiful paper in Archive of Neurology in 2002. Recently, there are also other atypical presentation with upper limb onset polyneuropathy mimicking carpal tunnel syndrome, and pseudo-CIDP is another presentation also in misdiagnosis, and very few cases of motor neuropathy. This is a typical familial amyloid neuropathy described 70 years ago in north of Portugal by Corino Andrade, who has written the majority of the chapter of this disease. You see on the left the autosomal dominant transmission of amyloid neuropathy in young people start around 30 years old. And this is a length-dependent small fiber neuropathy. Patients complaining of painful feet, anesthesia of the feet extended proximally to the knees and after to the thigh, and waning the ends. And on the examination, you have a especially small fiber involvement with loss of pain and temperature loss, but proprioception is preserved, and also the light touch also. The postmortem study at the time discovered in the peripheral nerve amyloid deposits in the endothelium, destroying the fibers around. And this is a in vivo nerve biopsy showing by the red Congo the same picture 60 years later. This is a difference Professor Haruki Koike described in Japan. There is a small endemic area in Japan, but also in every part of Japan we can see late onset. That means people starting after 50 years old, and early onset you start before 50 years old, like in Portugal, for example. And the major difference according to these two populations is, of course, the age and the gender. There is a male predominance in late onset. This is the same in France, in most countries. The family history is common in early onset group, but very uncommon in late onset. The family history is lacking usually. The neuropathic sensory motor dysfunction is in the majority of late onset, and autonomic symptom is very uncommon at the onset. Conversely to early onset with the V30M variant, with half and half, you can have sensory complaining at the beginning or autonomic dysfunction at the beginning, half and half. The superficial sensation is dominantly affected, pain and temperature loss for the early onset, and you have all modalities, superficial, pain, temperature, and also proprioception. This is the upper limb onset polyneuropathy, which is quite different. This is a recent series of 31 patients from the French center. The mean age onset is late, 63. There is a male predominance, as you can see, 5.4. There is 8 different mutations, conversely to early onset V30M. The delay for this diagnosis is quite long, and misdiagnosis is about 75%, with 15 various diagnoses at the beginning, including carpal tunnel syndrome, for example. The NIS in this NIS is a score of neuropathy impairment score, usually affecting the feet, to assess diabetic neuropathy, for example. And usually the NIS in the feet, in lower limbs, is major and null in the upper limbs. And in this subpopulation, you have an NIS score in upper limbs, which is superior of lower limbs. This is a quite specificity. On the right part of the slide, you can see the major involvement of the hands with amyotrophy of anterosseous muscles of the hands, and you have different sectors of median, ulnar, and radial nerves which are severely impacted. Conversely, in the feet, the muscle of the legs are quite preserved. This is quite atypical. The pseudo-CIDP, as reported recently in 13 patients by Pierre Lauseron, it represents in a non-endemic country about 50%. They fulfilled all EFNS-PNS definite criteria. It is late onset people with 62 years old at the onset, and the gender is also a male predominance. There are different TTR variants, essentially V30M A, VAL107, and tyrosine 77. We found some red flags versus idiopathic CIDP or POEMs. Clinically, it was the predominance of neuropathic pain, some dysautonomia, some small fiber sensory loss above the wrist, and weakness in the upper limbs. Also, electrophysiological red flags, which prolong distal motor latency in the median nerve, motor axonal loss, most commonly in the median, and some cutoff for sural nerve snap amplitude below 3.9 microvolt. Motor neuropathy is very uncommon. In the recent review, there was about 10 cases by Pierre Lauseron. Presentation is weakness in the upper limbs, dysarthria, difficulty slowing, and atrophy of the tongue. And there are about 6 different TTR variants. On clinical examination, compared to ALS, there is no upper motor neuron sign of dysfunction. And if they have no complaint of sensory complaint, or on examination you have no sensory loss, but you have to pay attention to nerve conduction studies, you have sensory abnormalities. That's why for these patients, we made the nerve biopsy, because there was decrease in radial sensory nerve amplitude of snaps. And we found in this patient, of course, a reduction of axon in the endothelium, but also amyloid deposits, and we found a new TTR variant. The misdiagnosis could be motor neuropathy, ALS, and we have now 4 other patients with this presentation in France. This is a characteristic of the large series of 180 patients published recently 3 years ago, and to see that we represent the 3 most common variants of TTR in our French population. We have on the right a large Portuguese origin patient with a MED30 variant, but you have also the VAL107 and tyrosine 77. You can see that the age of onset in this population is late. There is a male gender predominance. The positive family history is very uncommon in this population. And interestingly, there is an history of carpal tunnel syndrome in most of these patients, with sometimes carpal tunnel syndrome surgery. The initial symptoms is paresthesia, sensory disturbances, and pain. in this patient, but you can have also weakness, pure weakness in some patients with this variant, or GAIT disorders starting manifestation of the disease. The diagnostic tools for TTR amyloidosis with polyneuropathy is biopsy to find amyloid deposits. The biopsy is able to find a huge amount in the nerve biopsy performed 20 years ago, but you can make a small invasive biopsy, for example, labial salivary gland biopsy, and you have typical amyloid deposits. You have to know that negative biopsy sample for amyloid deposit does not eliminate diagnosis of ATTR amyloidosis. The sensitivity is ranging from 70 to 80 with this biopsy, but it's not 100%. And sometimes when you are convinced that it is amyloid, you have to convince the pathologist to have a second look, to make serial section, and to pay attention on the different section to find sometimes tiny deposits. Another recent tool is cardiac DPD, dephosphonate scintigraphy, which is typically a scintigraphy, a bone scintigraphy. But in this, in TTR amyloidosis, you can have a fixation in the heart, like you can see in this patient, with not in the bone, but in the heart. This is a biomarker. And you can, if you have, it can avoid to make a myocardial biopsy, for example. The second major tool is genetics. You have to find ATTR variant by TTR gene sequencing. I explained to you that there were a lot of numbers of variants, so you have to look for VAL30M A, but it can be 50 or more different variants. And to check, this is if it's declared ATTR variant, there is this is a different variant. This is a hot point for the TTR amyloidosis with peripheral neuropathy, the VAL30M, and this for the TTR amyloidosis with cardiopathy. This is VAL120. This is an interesting website in London, supported by UCL and the British Reference Center for Amyloidosis. This is the address, the website. You can check if the mutation is reported. For example, you see the Bicêtre. This is a non-amyloidogenic mutation. This is a polymorphism you can find in healthy people. Another mutation, for example, is VAL28M. It is a variant inducing polyneuropathy in some Portuguese families. So this is very important to see if it's if you found a mutation in a patient with polyneuropathy. You have to check if it's a amyloidogenic mutation or non-amyloidogenic mutation. I put on this table the different misdiagnoses in ATTR variant polyneuropathy, which is really a CAMELEON-like neuropathy. And it was usual not to make the diagnosis the first time you see the patients. It depends on the presentation of the patient. If it presents with a length-dependent small fiber polyneuropathy or autonomic neuropathy, usually this is a genotype. The misdiagnosis, it could be the diabetic polyneuropathy, it's the beginning, or fibromyalgia, or eventually light chain amyloidosis can do the same. And if you start with chronic digestive disorders in autonomic neuropathy, you can consider it maybe it could be chronic digestive disease. When you have all fiber polyneuropathy, like late onset in Japan population, with the same VAL30M, you can have different misdiagnoses, and usually it's CIDP, but it could be also idiopathic axonal polyneuropathy, lumbar canal stenosis in elderly, vasculitic peripheral neuropathy, toxic neuropathy, and so on. When the neuropathy starts in upper limbs, you can ask, could be carpal tunnel syndrome, but the neuropathy, in spite of surgery, progress, and it could be a red flag. Idiopathic polyneuropathy or CIDP, eventually paraneoplastic neuropathy if you have a patient who has lost 20 kilos with sensory painful neuropathy in upper limbs, or cervical radiculopathy. For motor neuropathy, this is a different genotypes associated. Could be, as explained before, ALS, motor CIDP, motor neuron disk. There are the red flags proposed by Professor Conceição from Lisbon, from the reference center in the south of Portugal. Because when you have in front of you a patient with a peripheral neuropathy, what are the red flag symptoms? Could be interesting. Interesting is the progressive symmetric sensorimotor neuropathy. Progressive neuropathy, that means when you see 6 months later the patients tell you new symptoms or extension of previous symptoms. It's not the same as 6 months before, so you have to pay attention in this field. Of course, when you are in Portugal and you have a positive family story, it's quite easy to join the two parts and to say he has probably FAP. When you have autonomic dysfunction with sensorimotor neuropathy, of course, if diabetic, you will think diabetes, but if not, you have to pay attention to amyloidosis. Unexplained weight loss. Some patients start with unexplained weight loss for 10 kilos with peripheral neuropathy. You have to pay attention for this cause. If you have a cardiopathy also associated, if you have patients with pacemaker, for example, if you have a patient who underwent carpal tunnel syndrome surgery before, vitreous opacities, and also the additional alert explained and proposed by Professor Conceição is a rapid disease progression. And if you think about CIDP, the failure of IVIG and no response for this treatment. Probably for non-endemic areas in the world, you have to work on a new proposal for red flag symptoms. Probably the GAIT disability is very important, and atypical CIDP, and non-responsive to IVIG. After you have made the diagnosis, you have to make staging the disease. You know it's a peripheral neuropathy, so the neurologist has to pay to stage the neuropathy. The sensorimotor involvement, you have a score of neuropathy impairment score. You have the strength in upper limbs with grip test in JAMAR. You have the PND score, I will explain later, and you have functional scores, so RODS. For autonomic dysfunction, you have scale for COMPASS 31 or CADT, heart rate variability test to assess the cardiovascular system with Valsalva, for example, and you have the skin conductance with pseudoscan, for example. For systemic amyloidosis, you have to have a collaboration with in a multidisciplinary approach with cardiologist and also ophthalmologist. So cardiologists have to check for conduction disorders and using sometimes pacemaker implantation. Cardiac insufficiency at the eye, you have to have ophthalmologists looking for glaucoma or vitreous amyloidosis or dry eye, so on. And for the kidney, you can see if there is any proteinuria or increased creatinemia. The staging of the GAIT disability is very important for these people. The classical staging is FAP staging, proposed in 1980 by Paola Contino. So stage 1 is the patient has essentially symptoms in lower limbs, but he can walk unaided, and sometimes some walking difficulties. The stage 2, you have to walk with aid, with assistance, and the stage 3 is the patient is wheelchair or bedridden. The PND is more detailed. That means you have PND1 is only sensory disturbances and no walking difficulties. You have PND2 for difficulties in walking but no aid required. And the stage 2 between the PND3A and 3B, the difference is one stick or crutch or two stick or crutches. And stage 3 is, or PND4 is the same. The patient is wheelchair bound. This is progression of the Portuguese form, the early onset VAL30M, which is slowly progressing on 20 years. That means the times to have walking difficulties, you have to wait 5 years to have walking difficulties, to need after 1 cane, 2 crutches, and so on. And so we have a long period of sensory polyneuropathy in these patients. For the late onset and other variants, it is disabling neuropathy with rapid gait disturbances. For example, you need for the different variant, late onset mid-30 to have walking difficulties. You need only 2 or 3 years to have walking difficulties. So a patient with recent peripheral neuropathy, late onset and coming with walking difficulties at your consultation is quite uncommon, and you should be. This is the risk of and the delay to have assistance with walk according to mutation, and with early onset mid-30, you have to wait 8 or 7 years to have a walk, I mean delay to have a aid for walking. But you see for the different variants, to need require a cane, you have only 3 or 4 years to have that. This is to see the variable sensorimotor severity according to genotype. This is a multinational natural history study. United States, Italy, France, Portugal participate to this trial, and we have a Portuguese patient with early onset V30M, late onset patient in our center essentially in Italy, and also non-V30M. And the NIS score with normal score is 0 and the major is around 200. And you see there is poor motor involvement in Portuguese patient with early onset V30M. The score is around 9. Conversely, in late onset and V30M, you have increased score because you have motor involvement in these patients. The mean is about 38, 90, 59 in this patient. And you have good correlation between the PND score and the NIS increase. Interestingly, the upper limbs are often involved in these late onset people, and the JAMA is very useful to measure the impact on the strength in upper limbs. And you can see when you have a PND1, you have a nearly normal strength in the upper limbs, but the more advanced the neuropathy, and you decrease the strength and you can have complete paralysis in the hands at the advanced stage. The hallmark of the amyloid neuropathy in late onset, for example, V30M, is a progressive neuropathy. So every 6 months when you see again the patients to have a control consultation, you have new symptoms I explained before and worsening of previous manifestations. And this is description by Haruki Koike in a large series or late onset to see the course and showing this is a progression. Every 6 months you have a new manifestation, for example, sensory symptoms in the feet, in upper limbs, motor symptoms, digestive symptoms, and onset of use of cane. And there is only few months between all these steps. The duration of the disease is shorter than in Portugal, 7.3 years. And the cause of death is cardiac insufficiency or sudden death. This is interestingly, the course depending on the genotype and phenotype. For example, for early onset V30M, you have to wait 6 years to have either cane for walking, and some late onset you have only 3 years. So very interestingly. And for the survival, you see the early onset V30M are survival about 20 years from the onset, and the late onset V30M is shorter, about 7 years in French and Japanese study. And you have two severe forms, the VAL107 and the LA60, which is typical British Irish variant. The therapy, once you have made diagnosis, you have staged the disease, the next step is therapy. So you have to, symptomatic therapy part is very important. The painkillers, they have neurogenic pain. The rehabilitation is very important, and treatment of autonomic dysfunction, diarrhea, erectile dysfunction, orthostatic hypertension. Anti-amyloid therapy is also important with now 4 different treatments. This is amazing. TTR stabilizer, patisiran, inotersen, liver transplantation. And also you have to eventually to manage organ involvement with cardiac conduction disorders, pacemaker, dialysis if there or kidney transplantation for severe renal involvement, heart transplantation with end-stage heart failure, and ocular therapy. Of course, genetic counseling of siblings and children is crucial. Detection of carriers, TTR gene testing, follow-up these patients in referral center, and you can propose eventually prenatal diagnosis or pre-implantational genetic diagnosis. This is a progress done during the last 20 years. Before 1990, nothing to propose for these patients. And liver transplantation proposed first in Sweden in 1990, and generalized later in other countries. First clinical trial on TTR stabilizer, the flunizole, the tafamidis, and first clinical trial on TTR stabilizer in the 2010. With patisiran, with Tegsedi, and marketing authorization in 2000 finally with Vandakel for tafamidis, and recently in 2018 ONPATTRO for patisiran and Tegsedi for inotersen. This is the mechanism of approach of ATTR to treat ATTR amyloidosis, to remove the liver to prevent TTR production, the mutant TTR production. And but the chess of liver transplantation in late onset people was due to the production of normal wild type TTR. So TTR gene silencing was built to block production of both mutant and wild type by the liver after peripheral administration. To prevent TTR monomer production, TTR stabilizer here. And next step in the future could be to remove amyloid deposits with monoclonal antibody, the serum amyloid P component, or anti-TTR monoclonal antibodies. This is to show the efficacy of liver transplantation on the neuropathy shown in 2000 in brain in a large cohort of first 45 patients. We had a dramatic TTR knockdown in the serum by 98% of the mutant TTR in the serum, and most of the patients were stable at the stage 1 after 4 years of follow-up clinically and electrophysiologically. And now we have a result of the register, world register of FAP in ATTR amyloidosis around 2,000 people. And you can see the long survival of this patient, especially the blue line, which represents the early onset VAL30M A, essentially a patient of Portuguese origin who have a long survivals. We have now doubled the survival of this patient, which is a fantastic result. Conversely, the late onset of the same mutation and the other variant have not the same results. That's why probably due to the wild type TTR deposition in the different tissues. What are the limits of liver transplantation also in ATTR polyneuropathy? Ocular complication. I explained that there was also production by the retina of transthyretin, so they are developed even after liver transplantation. Major complication of glaucoma, vitreous opacities, and some of them are developing blindness. This is the risk of complication after liver transplantation, after the time, and the risk of ocular manifestation increase with time. Another complication is brain. Choroid plexus are producing amyloidosis, and it could be with time, with long survivor complication, as reported by the Porto team. The risk of focal neurological episodes, negative episode like a TIA or a stroke or like episode, or episodic epileptic seizure. And one of these patients died from cerebral hemorrhage, and the post-mortem study found cerebral amyloid angiopathy. This is the first drug as a disease-modifying therapy for TTR amyloidosis. Tafamidis. The mechanism of action is to occupy the site of tyrosine binding protein, so to stabilize the tetramer and to avoid the misfolding protein aggregation in the tissue and amyloid formation. The trial was coached by Professor Coelho in Porto concerning early onset V30M, 125 patients with 20 milligrams of tafamidis. And we can see the population has very early stage and minimum neuropathy with a score NIS about 4 at baseline. The patients, 87 were available during the 18 months period, and the primary endpoints were in the response of 2-point change of NIS in lower limbs. The quality of life was important, and you can see that the patient receiving tafamidis had reduced progression of the NIS lower limbs compared to placebo. The long-term effect of tafamidis in late onset V30M and other variant was studied in in other teams in France, in Italy, and as you can see, the tafamidis was not able to prevent the progression of the neuropathy and disability in late onset, but you can see the neuropathic score was higher, was about 53, 31, 34 compared to the NIS score of 4 in the Portuguese population. RNA therapy is a TTR gene silencing. This is an innovative therapy and quite revolution in the 21st century. The idea is to target the gene to reduce the production of and to block RNA messenger and not the gene, and going and targeting the hepatocytes by lipid nanoparticle around the RNA specified for ATTR. The result after intravenous infusion was the major and rapid TTR knockdown compared to serum concentration baseline, and after a certain dose we have in a patient a major reduction of about 80% of circulating mutant TTR and also wild type normal TTR in the serum. So it was a fantastic result in the phase 1 trial performed in Europe. The role of RNA therapy is to block the production of wild type and mutant TTR in the serum, to reduce the production of new amyloid deposits, and to stop the progression of the disease and eventually to reverse it. This is the design of the trial Apollo, which was quite complex trial. A patient received in two-thirds of them a patisiran 0.3 milligram per kilo by IV infusion or placebo. The primary endpoint was a composite neuropathic score at baseline, and was studies a change from baseline to 18 months. There is many secondary endpoints: quality of life, strength, disability, gait speed, autonomic symptoms to catch the maximum information. At the end of the trial, most patients were still in the trial. This is the recruitment of this trial, a worldwide recruitment, North America, South America, Western, and also Asia, 44 sites, 19 countries, and Europe was the major recruitment site in the world, with United States. As you can see, the people are late onset, usually male gender, and the genotype were half V30M and half non-V30M. They were balanced for FAP stage. They were balanced for PND score, PND score 1, 2, 3A, 3B, to have the different kind of severity. The first result of the trial was a major TTR reduction of this in the serum, rapidly and 80, and lasting all over the trial of 18 months. This is the first biological reduction. And for the primary endpoint, you have a dramatic results with compared to placebo. As you can see, there was a large statistical significance compared to placebo. This is the natural course in pink, with increase with time at 9-18 months of the composite score. This is a severe natural history of the disease. And conversely, with patisiran, you have something very surprising. You have reduction of the score, meaning probably some reversal of the disease. For the quality of life is the same. You have improvement of quality of life at 9-18 months compared to placebo with deteriorating quality of life. Half of the patients improved the neuropathic score and the quality of life at the end of the trial, which is quite fantastic compared to placebo group here. All the secondary endpoints achieve statistical significance at 18 months, and especially you have increased speed of walking in these patients, improvement of autonomic score, compass in this patient, and the RODS, this is a functional score, was exactly the same at the end of the trial in patisiran group, deteriorating in placebo group. Another TTR gene silencer is inotersen. This is oligonucleotide antisense. It's not specific targeting of a hepatocyte because it can go in different tissue, but it can induce TTR knockdown, as shown previously in experimental models. Here we had 172 patients with different stage of the neuropathy, and we have viral ultimate and also non-viral ultimate. So there are two primary endpoints, Norfolk quality of life and composite modifying S+7. This is the result after 15 months of the trial, and you can see a statistical result, positive result for the inotersen at the end of the trial compared to placebo. And we can see that we have a dramatic slowing progression of the disease with the quality of life and also so modifying S+7 at 19 months. There is some concern for anti-amyloid therapy safety. For tafamidis, there is no problem with some risk of urinary infection of diarrhea in this population, but nothing serious. For patisiran, some reaction to infusion of edema of the feet. And for inotersen, you have a risk of thrombocytopenia or glomerulonephritis. So the control of platelets every 15 days is required before any subcutaneous injection because the treatment is administered by subcutaneous injection. Now we are moving to a new era, so probably 95% of ATTR amyloidosis with polyneuropathy could have disease-modifying therapy. This is a revolution. So according to the stage, you can propose, for example, for stage 1 with marketing authorization tafamidis, and discuss eventually to propose patisiran or inotersen, or if progressing, you have eventually to discuss liver transplantation with very early onset patients. For the stage 2, you can propose patisiran or inotersen. Both have the marketing authorization in Europe and EMA. For patients with severe neuropathy, we have to discuss combined kidney and liver transplantation. And for severe end-stage cardiomyopathy, combined heart and liver transplantation. Genetic counseling is crucial for these patients. As I explained before, so the genetic counseling detection of carriers is crucial. You have to have periodic monitoring, eventually for new symptomatic patients to have a small biopsy to find deposits and to start very early treatment within the first year. This is a interesting genetic study for genetic counseling showing that for early onset patients of Portuguese origin, you can see that at 90 years old, almost 85% have declared the disease. For the late onset in France, for example, you have only 18% who declare the disease at 50 years old. But later, with aging at 80 years old, most of them had declared the disease. So the detection of the carriers is crucial for the management. So this is the follow-up of carriers by periodic consultation with neurophysiologic test, and in patients when becoming symptomatic, the proof of amyloid deposits to start very early the treatment. So the conclusion in the last 30 years from an unknown disease, endemic hereditary disease in young subjects, and incurable disease in the 80s, we have now a better recognized and treatable disease. TTR silencing by reducing both mutated and wild-type TTR largely controlled transliterity in amyloidosis. The patisiran, onpattro, and inotersen were approved by EMA FDA in August 2018. They offer first-time access to anti-amyloid treatment for the majority of patients with FAP. And onpattro offers for the first time the possibility of eventually functional recovery. The perspective and what are the long-term efficiency of and tolerance of both new TTR gene silencing therapy. We have a prospect of long-term effect of subcutaneous with 3 months effect with new protocol. This treatment will be efficient for heart involvement. What about the ocular involvement? What about cerebromingular involvement of ATTR amyloidosis? We need innovative approach by the pharmaceutical company, but I am very confident for the future, according we have the progress we had. And of course, it's very important to have an early detection in carriers of the onset of the disease. So that's finished.
All right, thank you very much. Does anybody have any questions at all?
Here is David speaking. Thank you very much, David, for this exhaustive, comprehensive, very clear review of the field. Very interesting information. And there may be several questions, but one that comes to me is how do you explain the variability in the phenotype, early onset versus late onset? Do you think the role of the full length and fragments of amyloid, for instance, of TTR is an important issue? And
yes,
so
yes, not detailed, but Sweden team of Professor Westermark and Professor So in Sweden have shown that biochemically there is the fibrils are not the same in early onset and late onset. It's very short fibrils in late onset. Probably the same in wild type senile amyloidosis. So, and using more severe complication and with especially cardiac involvement with very infiltrative and restrictive cardiomyopathy. This is a first point. We have many questions according to the variability on also from according to the age of onset. I don't know. There is probably genetic mechanisms which are very important to discover. The difference of the ratio of gender, I don't know why men are so involved in this disease with a gender ratio as high as 5, for example, for male to female. So I don't know. You are a famous geneticist. What about, what do you think, Davide?
I'm following the literature, and I've seen there are many studies about the role of modifiers, including the androgen receptor gene, for instance, and also the cleavage of the TTR into the fragments regulated by plasmin. And so this is an evolving field, very interesting, also maybe for the therapy in the future. We do see the same pattern in Italy as you in France with the late onset forms and the male predominance. Maybe we should perform a European trial on this study on this field. This is a very good suggestion, and also the EARN may be of help from this point of view. I'm sure we could have the samples you need to do that. Yeah, yes, definitely, definitely. This is a good suggestion. And what about stage 3 patients? The treatment is a problem for these patients as those chair-bound. This is a very good question. These patients are not so many in my experience, probably less than 5%. I think we, as a compassionate use, we can defend this approach because even if they are wheelchair-bound, they are useful hands, and for their autonomy, it's very important. So I think we can defend a compassionate use for this patient, even if we have to give some criteria, but we can assess this patient with Rhodes scale, for example, or with JAMA to see that they preserve their autonomy in part of autonomy. So I think if we have to defend them together to give therapy for this late stage, I think we have the argument to do that. Yes, the rationale is there, obviously. Yes, I agree.
And is there any other questions at all?
Hi, this is Hans Lockmüller. Thanks for this nice webinar, David. I just wanted to clarify in relation to start of treatment with these new drugs. So in your view, is it sufficient if you have a mutation carrier that becomes symptomatic, like with what you said, bilateral carpal tunnel to start treatment? Where is the sort of starting criteria?
This is a very good question and controversial question. We have no consensus when to start and when to change because we have now 4 different therapies and we need the consensus to have the same criteria from one part of the country to another and from one European country to another one. And probably it would be interesting to debate on this field and the next European meeting, which will be in Berlin at 2 and 3 September. We need a expert meeting altogether to define some consensus. I have my opinion, but we need altogether to exchange and to propose something maybe after Delphi survey, for example. But a carpal tunnel syndrome is difficult because it comes 10 years before the onset of the real polyneuropathy. So with a very expensive drug, it would be difficult to defend. But we now start therapy as soon as a young Portuguese patient complains of burning feet. We perform the skin biopsy. We found denervation and small amyloid deposits. And we start now the treatment. So we can do very early, but we have to put on the paper all criteria to start early altogether treatment, because it's very important.
Okay, thanks. Very, very helpful.
And any other questions at all? No. Okay, well, thank you very much for presenting that webinar.